why don't we get started? And thank you for joining us, Mariana. And we'll see who else joins on. We'll probably gather a few people, but the floor is yours. And let me just start by saying that this is our monthly mental health speaker series, coordinated by District 6440 in Rotary, which is the Northeast Illinois communities, 60 some clubs, 1,800 Rotarians doing great service around the community and around the world. So mental health was a focus of the Rotary International president in 23-24, which was what the year that I was district governor. And it has continued throughout the world as being a major initiative of Rotary. So we're doing our small part to continue to educate people about what resources are available and how to identify issues that may be in their home, their workplace, their social setting, or whatever. So with that, I'll turn it over. I'm not sure who's going first, Dr. Kemp or Kate.
Yeah, I will kick us off and
Hey.
thank you again so much for having us today. So, we're going to talk a little bit about navigating mental health awareness, treatment, and resources, very appropriately timed as it's Mental Health Awareness Month. And I'm going to first introduce myself and then I'll let Dr. Kemp introduce himself. So, I am Kate Adams Smith. I have a master's in social work and I'm licensed. I'm currently in an MBA program as well. But for the last 4 years, I've been serving as the operational lead for a team of our therapists at Advocate Health in our medical group, and then also the behavioral health integration team. And very passionate about mental health. My background primarily has been working as a social worker in mental health and medical settings, including as a hospice social worker. And very passionate about volunteer work. I like to blend creative abilities and expression with community service and volunteer. So with that being said, I will hand it over for Dr. Kemp to give his introduction.
Hi, good afternoon. Well, thank you for having us today. I'm Dave Kemp. I'm one of the psychiatrists that work with Advocate. I'm the medical director for our behavioral health program for Illinois. And clinically, I work on what we call our consult liaison service. So if there's any type of psychiatric or behavioral health needs, that come up with patients who are on our general medical or surgical floors or in our emergency rooms. My team addresses the needs of those patients, and I also have a small outpatient practice in the Palos Heights area. Thanks again for including us today.
Yeah, thank you. So, just going to go over the agenda very briefly. We're going to talk about stress and grief, and then when and where to seek help, because sometimes that's not always obvious. There's a lot of resources, there's a lot of different outlets, but we'll talk a little bit about what to do when you're experiencing a mental health crisis or maybe just feeling overwhelmed. And then I will turn it over to Dr. Kemp to talk about the differences between psychiatry and therapy or psychologist, and then some common psychiatry myths, treatment options, and then finally we will just do a high-level overview of some of the mental health programs that are available currently at Advocate. You'll see me kind of sprinkle those in as well as some other community resources. So with that being said, I'm just going to start with talking about understanding stress. Stress, as we all know, impacts everyone. So one of the things is that we don't talk a lot about is how to identify stress. Not one size fits all. People can identify stress through physical symptoms, mental health symptoms, and it can be apparent in daily life, but it's really important to identify when it's impacting your ability to function or live well, because that's when it can be maybe the point where you need to reach out and get some help. So there is a couple different things. Obviously, like I said, everybody experiences stress differently, and it can happen in different stages of life or throughout your daily life. But just talking about the season right now is the spring. We've got summer coming up very quickly, a lot of travel, a lot of family plans. I'll talk a little bit in grief. We'll talk about Mother's Day, Father's Day, but just understanding the ways to not only identify it, but then to cope with it. So Accepting our needs is a huge thing. A lot of times we're moving so quickly through our daily lives and trying to keep up with multiple competing priorities that sometimes we don't sit down and kind of accept those needs. What do you need right now? Do you need that break? What is that coping mechanism, excuse me. So self-care really is for everyone. I know we talk a lot about it in our general society, but it really is. So self-care can be from anywhere. It doesn't have to be a grand gesture of going out and doing something lavish, but it can be as easy as just taking a few minutes for yourself and doing a hobby you enjoy, or maybe taking a walk. So just identifying ways that best cope with stress. Of course, in our medical group, behavioral health, we always just talk about our wonderful therapists, psychologists, and even psychiatrists. And just if you're needing to seek help and talk to someone, that's always a great outlet as well. But practicing relaxation, exercise, setting aside time are a lot of great ways to identify and cope with that stress. And then we can't talk enough about how helpful getting appropriate amount of sleep is, and then talking to others when needing it. So self-care has a lot to do with not only your physical and mental health, but emotional health, and then also being a part of the community. So that is what we want to go over just about stress, as I'm going to go a little bit deeper into navigating grief. As I said earlier, I'm a former hospice social worker. I spent a lot of time talking about grief and coping with individuals, and also individuals who are terminally ill and their families. So I know grief is not always an easy topic to talk about. It can be awkward to talk about, but sometimes we see grief as very much a one size fits all, and that's not the case. So just wanted to talk a little bit about the different types of grief and how to use a routine to help with those symptoms. So the first thing I always stress is that grief does not just cover the loss of a loved one or a family member. It can cover a variety of topics. So grief of a pet, loss of a job, loss of a relationship, loss of financial stability. You can deal with grief from that. Maybe you've lost a goal or dream that you once had, your youth, fertility. There are so many different things that we can grieve in different ways. And it's important to identify those different types of grief, because sometimes we hesitate, and I'll speak for myself. Sometimes I don't put the label of grief on what that is, and I have to identify that, and that helps me to cope with it. So using a routine in your daily basis and just keeping a pulse on that can really help, just to understand where you're at in your grief, whatever that grief may be. And then also, just going back to anyone that has a loss of their health, maybe they're battling multiple chronic health conditions, physical and or mental health. Grief can very much come in that process. I talk to a lot of people about their loss of independence. People can very much grieve the loss of independence when they're no longer able to ambulate or move around as they once were, maybe not able to drive a car or do things as freely as they could before. So it's really important just to talk about those different things. And then I also wanted to interject. I recently was in a seminar just about grief and loss, and the speaker, Rebecca Fanglos, talked about, I really just love this, and I wanted to interject this. She talked about that grief is not linear. So many of you may know about Elizabeth Kubler-Ross and the 5 stages of grief. If anybody doesn't know, those 5 stages of grief that were coined quite some time ago are denial, anger, bargaining, depression, and finally acceptance. And when we look at that, many people see that in a line, just one after the other. Well, grief is not linear. And I really, again, to quote Rebecca, I really loved that saying is, grief can move in different ways. It can come in waves. It's not a situation where you see one person grieve and then you do the same thing. It's very different. So just to talk a little bit more about types of grief and just how those different types can really impact you. So the first example is anticipatory grief. So I recently went through that with my own father, talking about the upcoming holidays of Mother's Day and Father's Day. A lot of people experience grief around many holidays after loss of a loved one. But my dad was declining fairly rapidly, and I had a lot of that anticipatory grief. So I was grieving my dad's loss before his passing versus the aftermath after passing. So anticipatory grief is a very real thing. It's very normal. And we encourage people to seek help when needed for that. Some people experience abbreviated grief. It happens very quickly. You grieve and then you might not feel the grief again for a while. And in the reverse, there's delayed grief. So you might experience the loss of a family member, a loved one, a job, and you don't grieve. And maybe weeks, even months later, you feel that grief and those symptoms come up. So very important just to let yourself grieve in the way that feels best for you and not following anyone else's timeline or maybe things you see online. It's very important to just recognize those feelings. And then cumulative grief can very much happen and happens to many of us, unfortunately. And that's where you experience multiple grief or loss at the same time. So example, losing a loved one and then also losing a pet. Maybe you've lost your job and therefore you have to move. So you've lost a community or a neighborhood. So there is many things that can compound in grief, and it's important to identify those. And then finally, collective grief. I don't think we spend enough time talking about collective grief. That happened to all of us during the pandemic. So many changes, our routines, our daily lives were shifted drastically. And that grief can be in a community. It can be a collective grief that we're all experiencing together. So just important to talk about those things. And I know this is a very high level, brief overview, but I did want to point out that Advocate Health does have many great support groups. And if you go on the advocatehealth.com, you can find those groups, including bereavement and grief support. And then going into just when and where to seek help for your mental health, which is so vitally important. So when to seek help, if you are feeling, again, that inability to function in your daily life, maybe you're so overwhelmed or you're coping with grief and you feel it's too much, that's the time to seek help. And additionally, if you're ever feeling a crisis, so if you are experiencing a suicide crisis where you are feeling about or thinking about thoughts of self-harm, right? That is very important to seek help in that moment. And I just want to highlight the 988 Lifeline in case anyone is not aware of that. That is the 911 for mental health. It is a 24/7 nationwide hotline that you can call at 3 a.m. This hotline is not run by Advocate, but is run by multiple different community settings. I cited NAMI here. That's the National Alliance on Mental Illness. They have some great resources. But this is a really easy number to remember. But when seeking help, you can always talk to your primary care physician. You can always talk to community members, anywhere that you feel comfortable. But that 988 helpline can be extremely crucial in moments of crisis as well. And then we just like to talk about screenings. I don't think we talk about screenings a lot. When you go to your doctor, when you go to a mental health practitioner, they're going to ask you a couple questions about depression, about anxiety, how you're feeling, and then maybe even talking to you about those thoughts of self-harm, maybe passive, what we call passive suicidal ideation, where you're thinking about it, maybe you don't have a plan. It's really important that the practitioners or the people you're seeking care with kind of know where you're at in that moment. Again, this is not linear. Everyone experiences this in different ways. So it's important to talk about that and share, because that's where you can get that help and hopefully start on the journey back to your baseline or wellness. And then I'm going to hand it over to Dr. Kemp to talk about the next few slides.
All right, thank you, Kate, for that transition. What I thought we'd do for this next portion of the talk is address some of the treatments and interventions that we have for depression, some new, some old, but also address some of the myths and misperceptions that commonly exist around them. And maybe the first place to start is just definitionally, if you are referred to a behavioral health provider, a lot of times people are confused by what is the difference between a psychiatrist and a psychologist. So I'm a psychiatrist. Psychiatrists have attended medical school. They tend to be very interested in the biological underpinnings of mental health and frequently as an intervention use medications to treat symptoms. And really try to address that overlap between what is, an underlying medical issue versus psychological issue. A psychologist has a doctorate in psychology. They tend to be more focused on behavioral interventions, psychological testing, and providing psychotherapy or counseling. And there's others who do work in this important space. Kate's a great example, a licensed clinical social worker. You have licensed professional counselors. So many people that are able to provide these behavioral interventions. And the good thing that we see is when you combine both approaches, you usually have the best outcomes for depression. So a lot of times people will see both a psychiatrist and a psychologist as part of their overall treatment plan. Now, on the next slide, I cover a couple of the myths that exist around antidepressant medications. One thing that makes people apprehensive is they feel, well, this is going to change my personality of who I am, or this is just like a happy pill, and I'll feel artificially euphoric. And that's really not the case of how these medications work. They're much more subtle. They work slowly over time. You don't usually see an effect until a couple weeks into treatment, and then see more of a full effect a couple months into treatment. So it's not like you'll take the medicine and the next day you're kind of bouncing off the walls with this high feeling. And it's really meant to restore your baseline personality before you became depressed. So often, if you're suffering an episode of depression, you may not be socializing as much with individuals, just staying in bed more, don't have as much energy. The antidepressant is meant to alleviate that and kind of bring you back to your baseline level of functioning and interacting with the world. The other common myth that is on the next slide is that antidepressants are somehow addictive. And that you will get dependent on them and never be able to stop them. And that's not true either. Antidepressants are not controlled substances. I know there's a lot of concern about those types of medications prescribed in the medical community, like opiates and benzodiazepines, which you can develop a tolerance to, and if you were to stop them, could develop withdrawal. That's not the case really with antidepressants. They're not controlled substances. They're not addictive. Now, that's not to say that you should just stop the antidepressant abruptly if it's prescribed. You really should discuss that in detail with your medical provider because some of them at higher doses, if you were to just stop them abruptly, you could feel physically ill. We call it a discontinuation syndrome. So you really need to work with the provider about how to mitigate that risk and come off the medication appropriately. But the important point is that these are not addictive treatments to address mood disorders. The other thing on the next slide that I wanted to cover, kind of a difficult area to talk about, and that is suicide. We have an astoundingly, alarmingly high suicide rate in this country, and this statistic is even a little outdated now. In 2024, there were a little under 49,000 deaths from suicide that year in the U.S. We at Advocate really try to be thorough in doing a suicide risk assessment, both for patients who are presenting with behavioral health concerns and even those just being admitted to our general medical floors. Depression, suicide is so common that we want to be able to address that and provide an intervention as soon as we can. For those of you who don't work in the medical community, there's still some things that you can do. One, if you are talking with a loved one, a friend who has depression, don't be afraid to ask about suicide. It does not plant the idea in people's head. It can be very informative and get them pointed in the right direction to try to get treatment. You'd be surprised how many times I talk with families where a family member has come in after a suicide attempt and they say, I had no idea he was thinking this. I had no idea he had been planning this for X number of weeks or months. I wish I would have brought that up and addressed it further. So I'd encourage you to do that. And the other way that you can help is by reducing access to lethal means. And what that means for some is removing firearm access from the home. That is a proven suicide prevention strategy. We know that if people do not have access, the suicide rate goes down. So ask if you can remove that firearm from the home. Maybe give it to a family member for safekeeping. If they don't need it, get it into the hands of police. But that is a way to reduce suicide. And then for the last part, I wanted to cover three different treatment options that are available in Advocate that are a little bit different from the traditional medication that you might get prescribed at the pharmacy. And those three treatments are transcranial magnetic stimulation, or TMS, esketamine, which also goes by the name of Spravato, and finally electroconvulsive therapy, or ECT. And we can start with the transcranial magnetic stimulation. And I think later in the slide deck, we even have a picture that we can show you as to what the device looks like. And if you wanted, you could even scroll forward to show that. And then Kate's going to come back around to talk about how to access this treatment. But what we're essentially doing is we're using a magnet to induce electrical changes in the brain. And you can see this firsthand if you position the device over the motor cortex and turn it on. You will be able to see motor movements. Maybe your arm is twitching, your muscles in your hand, your arm. You're able to elicit that response simply by triggering that magnet. What we do is we move the coil over to an area of the brain called the dorsolateral prefrontal cortex, which is implicated in depression. And when this area of the brain is stimulated for about 20 minutes a session, they do this 5 days a week for a period of time. It's been shown to reduce depression severity and is a FDA-approved treatment for that condition. And we can go back to the overview slide. As you see, there's minimal side effects. It's a very well tolerated procedure. Some patients get a headache or some scalp discomfort. But there's no need for anesthesia, no memory loss. It's really a well-tolerated intervention. The next treatment is esketamine. This is a antidepressant that is a nasal spray. And what's unique about it is its mechanism of action. Almost every single other antidepressant that we use modifies what we call monoamines in some way or another. Those are neurotransmitters like serotonin or dopamine. Esketamine, on the other hand, targets a compound called glutamate. And what research showed with a related compound called ketamine is that if you were to give this medicine IV to someone who is very depressed, within a matter of hours, the depression lifted. And if they were suicidal, the suicidal thoughts lifted. So that was a big breakthrough for the field because, as I mentioned earlier, usually with our treatments, we don't see any effect until at least 1 or 2 weeks in, sometimes months in. So to see a reduction in depression within hours was really remarkable. This kind of offshoot of ketamine called esketamine, it has to be administered either in an outpatient office or a hospital. You can't just go to the pharmacy to pick it up. Because there is some monitoring that needs to take place. But you do this 2 times a week for a series of weeks, and it is FDA approved for treating treatment-resistant depression. And then lastly, I did want to discuss electroconvulsive therapy. This is where we induce a seizure in the brain to treat depression, schizophrenia, bipolar mania, a number of different psychiatric conditions. But I bring it up for two reasons. One, there's a lot of misperceptions out there in the community. And we see portrayals sometimes of electroconvulsive therapy that is really at odds at how the procedure actually works and how it's administered. Some of you may recall there was an old film called One Flew Over the Cuckoo's Nest that starred Jack Nicholson. And they showed somebody getting ECT, and the person is strapped down. They are shaking violently from the seizure, in a lot of discomfort. And that is not at all how ECT is administered present day. We use anesthesia to put the patient to sleep. They barely move because we give them a muscle relaxant. And the seizure itself is about a minute in duration. Then they wake up and they are discharged later that day. The reason we're still using ECT is because if you were to ask psychiatrists for the most difficult to treat patients, those who are not responding to multiple rounds of medication, maybe those who are suicidal and it's just not improving with psychotherapy and medicine, ECT is the best treatment that we have. It's the most effective at reducing these refractory symptoms. So that's why it is still part of our armamentarium today. So that cover hits kind of the main interventions that I wanted to discuss. So I'm going to turn things back over to Kate to review how to access them, and then I think we have some time for questions afterwards as well.
Yes, thank you so much, Dr. Kemp. So just to talk a little bit about those mental health services, I know you all saw the TMS flyer that we've included, but I put the main number here. We also have other services at Advocate, and of course, mental health is something that we are always partnering, collaborating with community resources and other places, but this is what is available within the walls of Advocate here in Illinois. So in case anyone isn't familiar with the abbreviations of PHP or IOP, that means partial hospitalization program or intensive outpatient program. And the closest location up in the north is that Lutheran General Hospital. So we've included the number there. But as you'll see, a lot of these programs are available all throughout the state. We cover all the way from the south side of Chicago, all the way to the north areas. So then we have the first episode psychosis program. I really love to put this in here because not a lot of people know about this. If someone has experienced their first episode of psychosis within 14 months, this is a grant program that is offered that can help that patient as long as needed. So that is the number there. And then the Advocate Trauma Recovery Center. They do some incredible work. So this is anyone that's experienced a traumatic event in the last 3 years. So domestic violence. There is no time frame on an individual who's experienced the loss of a loved one to homicide. So if somebody's lost a loved one in their family to homicide 10 years ago, that covers. So this is a team that really help tackle trauma and helping that person to recover and get back to baseline. And then finally, that ECT and esketamine programs. Good Samaritan is in the west mid suburbs, and then Advocate Lutheran General. You could call the Behavioral Health Call Center main line and just ask for that. And that is how you get a hold of those resources. And we are right on time. And then, yes, Mary, if we do have any time available for questions, we are happy to do so. But just want to say thank you so much, everyone on the call, and then anyone watching the recording for your time, as we always love talking about mental health services, and especially during this wonderful month of awareness.
Thank you, Kate. Thank you, Dr. Kemp. Very informative, not what people are necessarily thinking about when they hear about psychiatry and psychology. So one very simple question is, I know that there are lots of signs around our communities with regard to the 988 Lifeline. Is there enough? Do people really know what that is? Is it got enough penetration? What do you have any thoughts about that?
Yeah, that's a great question. They recently put up a sign. I've seen a lot around railroad crossings.
Yes, yes.
So I think it's wonderful that they're doing that for awareness. I live right by a railroad crossing and love that they put that there. That is a great question. So there is a lot of education because it's just going to take time. It's only a couple years old that it's been available throughout the US. But they do a lot of campaigns, a lot of community resources. We are always referencing it. So, likely, if you talk to one of our mental health practitioners, they're going to reference the 988 line. Or, of course, anyone can call 911 if they're not aware of that line. So, it's a really, really wonderful resource. But yes, NAMI and a lot of different National Institute of Health, a lot of different agencies do a lot of work to try to promote and educate. So, it takes a village. We will continue to speak 988 into existence, but I agree there might still be a lot of education. There might be people that are just not aware.
Right, and that's the kind of thing that Rotarians respond to because one of our nomenclatures is people of action. So, it's great to have an idea what tasks are needed, not to be the psychiatrist, not to be the behavioral health specialist, but to be the awareness provider. So if in going forward you encounter something like, oh, this would be a great opportunity to spread the word even more. I think that'd be wonderful to continue the conversation. So when you talked about the resources and you said people are identifying stress or they're identifying grief in their lives, where do you think we should go first? What would be the first call? What would be the first reach out that you would encourage? They're probably not going to get to Dr. Kemp or yourself the first call. Where would you go?
So
Other than 988.
yeah, other than 988, so your primary care physician is a great place to start. They can connect you. You can really, I mean, Psychology Today is a really great resource tool to find any therapist, counselor. You can filter settings, but also that number that I showed. We do have a main call center for behavioral health, that number right at the bottom here. So if you are seeing a primary care physician at Advocate, you can call that 855 number to schedule with one of our providers. So it really depends. Also, we understand people have different, they might have financial insecurities, they might have barriers. What actually is a silver lining from the pandemic is the morphing from in-person services to primarily virtual services, and not just your physical health, but mental health. So there is a lot of great resources. We serve a lot of virtual care here at Advocate, but another great resource is called Geode Health. That's GEODE. They are all throughout the Chicagoland area in Northern Illinois and are expanding. And you're going to see a lot more community resources like that have both in-person and virtual care. So really, because we're in a medical group, we always say, the first step would just be going to your doctor and talking about that. But really, there's no wrong way to seek help. Even if it's a Google search to see what's in your area.
I was just going to say, how do you feel about Google searches?
It helps.
I guess, yeah, if you don't go too far down the rabbit hole, right? And I think the other thing that I see on television a lot is, and this is to Dr. Kemp, there seems to be a lot of advertisement of drugs that work in the area of depression and mental health. And I'm not sure how good that is as a resource. Is that a real thing? Should people see, and I can't think of the name of any of them right now, but do people take these from on television and go use them or find them? How does that work?
Well, yeah,
It's
I
kind of
guess
scary to hear.
it can be helpful in that it raises awareness and it invites discussion. For, the patient might see something on TV and then they bring it up, and it gives you an opportunity in session to discuss the pros and cons and what's out there. But if you're starting a medication, first line, a lot of the times we go with a medicine that's been around for a long time, that's a generic that we have a lot of experience with. It may be very inexpensive, but still just as good of efficacy oftentimes as some of these newer medications that are coming out and that you see advertised. So I just think having an open discussion with the provider, that's kind of where to go with it, and the patient can learn a lot there, and sometimes that is the route to go. It kind of fills a niche where there's a gap that we have. That's why some of these medications come to market.
I have a question for Dr. Kemp, and it's precisely about those medications. I'm one of those that do not believe too much in prescription medicine. I prefer, conversations, therapies, or whatever, anything except chemical interventions. My son is takes depressant medicine. And recently, one of the parents I work with, her son started taking depression medicine too. But we know the cause of their depression. It's because of some experience and so forth. But my reluctance on medication is some time ago, we, as a neighborhood, we had a very dramatic experience with where we all had to intervene in a suicide attempt in the precise moment it was happening. We had to prevent it at the moment that this person was committing suicide, and it was extremely dramatic for us. And then after, he was sent for help, and the paramedics came and all that stuff. We discovered that it was he didn't remember any of that. Whatever he was trying to do, he didn't remember anything after he recovered. And apparently it was then assigned, or the cause of it had been determined that to be an overdose of the depression medication. And I have heard of other cases where people are driving and they are taking medication, and apparently that medication forces them to use the car and drive fast, or use it as a weapon, to hit something, or some kind of a release. So how do you determine that someone actually needs to take, pills or drugs?
Yeah, it's a great question. How do we determine kind of where to start and who is a good candidate for
It's too
medication?
easy, everybody, HDAD, okay, we give him a pill to calm them down, So
Yeah.
everybody finds a solution in a pill, and I don't like that.
Yeah, so for depression, the patient's own preferences actually influence the treatment response. So if you're somebody who really is kind of averse to medication, you prefer to talk about things in therapy, if you were to enter into a clinical trial, those types of individuals do a little bit better if they are randomized to therapy as opposed to a medication. On the other hand, if you're not so keen on opening up and having the therapy on a regular basis, if you'd kind of rather address it through a medication, we find that those individuals tend to do a bit better with the pharmacotherapy route. But as I mentioned earlier, for more severe depression, where you have more symptoms, maybe the suicidality is one of the symptoms, the best outcomes are when you combine the two approaches to use medication with psychotherapy. We see better outcomes than either intervention alone. So that's what we generally try to encourage, especially if somebody has been in the hospital recently because of mental health concerns, is to use both approaches to get the symptoms into remission.
Well, I think this has been a very helpful and informative session. I want to thank both of you for coming And I think, again, we encourage our clubs and Rotarians throughout the district to come back and take a look at the recording and use it for however they feel is most beneficial, including action projects and educational exposure. So I appreciate that, and I think next month we will see more from Advocate on different levels of care. I'm not quite sure Elizabeth is presenting that or who is, but we'll see you on June 1st. So thank you all for coming.
Thank you so much for
Right.
having us.
Thank you.
Thank you.